believing that medical therapy makes surgery an order of magnitude easier.
Okay, so you don't prescribe drugs?
I don't prescribe drug therapy for endometriosis because the historical basis of drug therapy is flawed, and that represents one of the biggest problems in the study of endometriosis.
Also, is it expensive?
Drug therapy for endometriosis can be quite expensive. Danazol can cost up to $150 for 25 days, perhaps more. There is a new drug that's just been approved, neferalin, which is given by nasal spray. It's a gonadotropin-releasing hormone agonist. I'm not sure what the cost of that is.
Menopause, how does it affect endo? You've mentioned...
The menopause is accompanied by complete cessation of ovarian function, and so the woman basically has little or no estrogen in her body. What this does to endometriosis is it makes it look visually quiescent. Any bleeding that had been occurring adjacent to the endometriosis now stops, and the body polices up that bleeding like cleaning up a bruised area. The disease, if there's any swelling around the disease, the swelling can go down. But again, there is no study of large numbers of menopausal patients with biopsy control that proves that the menopause is toxic to the disease and makes it go away. People can hurt less after the menopause, and that's good, but there are many patients who have been reported in the literature and in my own experience who still have symptomatic disease with estrogen levels that are next to zero.
In natural menopause with a woman who's into her 60s, is it possible that she could still have pain then?
The oldest patient with symptomatic endometriosis that I've operated on was 74. She had a symptomatic rectal nodule of endometriosis. She had endometriosis elsewhere in her pelvis. Yes, it had a very subtle visual appearance. We checked her body's estrogen level before surgery. She had none, and yet she was still hurting, presumably because of her disease, although maybe there was something else going on. But other authors have found symptomatic endometriosis after the menopause.
Childbearing, you mentioned that it doesn't eradicate the disease, but does it have some beneficial effects?
Pregnancy can make the pain of endometriosis go away while the woman is pregnant, although again there are reports in the literature of symptoms worsening during pregnancy. And women who feel better during pregnancy usually start to have their pain again a few months or a year or two after their delivery, because the beneficial effects of pregnancy are temporary, and pregnancy does not eradicate the disease.
Okay, how does your equipment compare with equipment in general use? Would it be any different? And would older equipment make successful removal of endo more unlikely?
If you were to see the equipment I use, you would consider it antiquated. I use an older model operating laparoscope. I use just the standard scissors and graspers that were supplied with that laparoscope. There have been no changes in that equipment for the last 10 or 15 years. I use, when I need cautery in the pelvis to control bleeding, I use a standard bipolar cautery that has not changed in design for 10 or 15 years. You don't need modern equipment to treat endometriosis successfully.
Endometriosis, you mentioned that in your video. Can you explain it with regards to your theory on how endo might be genetic? There's 12 or 13 different theories about how endometriosis is formed in the pelvis. Depending on who you talk to, you'll get a different theory presented. My own best guess model at this point in my career for the origin of endometriosis is basically an expanded view of the embryonic rest theory. The embryonic rest theory says that when the woman is an embryo and the various cells are migrating over here to form the heart and down here to form the pelvic organs, that the two populations of cells that are going to come and form the uterus, the muscular wall of the uterus and the lining of the uterus, as those cells are migrating down, the uterus forms before all of the lining cells get inside. And those cells just are arrested in their migration, and they sit there and grow. That's the embryonic rest theory. Now, it's been noted, and I've noticed in my own patients, that women with endometriosis have a lot of other gynecological problems going on.
many of them do. They have accessory fimbria on the fallopian tubes. They have little cysts in the pelvis. They have structural defects in the pelvis. They have structural defects that have been used to explain endometriosis by Sampson's theory, enhancing reflux menstruation. Women with endometriosis are thought to have more mitral valve prolapse of the heart than women without the disease. So when you step back and look at the bigger picture, you realize that these women with endometriosis have more frequently than just endometriosis going on. And it's almost as if something happened, to their bodies during development more commonly than happened to women without endometriosis. And so mulariosis is just a term for the model that I developed to try to explain why endometriosis can occur in the pelvis with perhaps an increased incidence of these other associated findings around the rest of the body. So it's an expanded view of the embryonic rest theory. It predicts, of course, that if the embryological development of the fetus is such that endometriosis is laid down in the fetal state, then you should be able to find endometriosis in women before they start having menstrual flows. And so I arranged to have autopsy material sent to me from young girls dying of crib death between the age of 2 and 6 months. And before the supply of material was stopped, we had about nine samples, from the pelvis of these young girls, and in one of those 9, there was definite glandular material in the cul-de-sac that looked very much like what endometriosis can look like in older women.
Have you found it runs in families at all? That the mother has it?
Yes, I think that there are certainly families where endometriosis seems to run among the women. Now, endometriosis is such a common condition that you don't have to look very far in a woman's family to find another female who has a disease. So are we seeing something that is just real common and so it overlaps in the same family? Or are we seeing something that truly has some hereditary predisposition? I think that there is some hereditary predisposition, but on the other hand, in most women it seems to be sporadic.
And you have found it, or it was reported to have been found in the bladder? As all gynecologists who are interested in endometriosis are well aware, endometriosis has been reported in the bladder and the prostate gland of males. And the obvious explanation for that, and getting back again to mulariosis, is that between 6 and 8 weeks of embryonic life, all fetuses, all embryos have female system and the male system, which develop in synchrony. And then if the embryo is a genetic male, the female system withers away, or is supposed to wither away. If the embryo is a female, the male system is supposed to wither away. However, not all the time does that withering away occur, and so some males are left with remnants of this embryonic, female tract within them. There is no estrogen in that male's life, so he has no problems until the male gets older and develops prostate cancer. And the treatment of metastatic prostate cancer is castration of the male, removal of the testicles, and then give the male estrogen to try to suppress the spread of the disease throughout the body. In some men who have this treatment, they've cropped up with blood in the urine. One thing leads to another. The urologist, eventually winds up diagnosing endometriosis of the bladder or the prostate. Do you treat many Canadian women?
I treat a lot of Canadian women. We've looked into getting a large maple leaf flag on a 50-foot flagpole in front of my office, but we're having difficulty finding a flag of high enough quality to do justice to these fine Canadian patients.
Why do they come to you?
People come to me from really all over North America simply because they're still being bothered with pain primarily, despite multiple previous attempts at surgical or medical therapy. And they have read about me in the lay literature, or perhaps attended a conference and heard me speak. And I'm told that a lot of what I say, makes common sense. Woman has disease in pelvis. The disease causes pain. There is no medicine that makes disease go away. Therefore, it's up to surgeon to remove the disease. If surgeon removes the disease, he's got to do a good job of identifying and removal of the disease to have a half a chance. So this sequence of logical events appeals to them. They can't get this sequence of events at home. They've tried everything that's been offered, and so they come to me for that reason.
Okay, I want to talk a bit about the quality of the operation in Canada and how it's affected by the billing practices, because I understand it's completely it is a different system whereby they get, it's a pitiful amount for an operation. And would that affect how long they operate for?
There are fundamental differences in the American medical system and the Canadian medical system. The American medical system is still partly fee-for-service private enterprise, although it is becoming increasingly socialized. The Canadian system is essentially completely socialized. I spoke with some Canadian physicians at a recent international meeting on endometriosis regarding their allowable charges for doing a laparoscopy. And I said, well, how much do you get paid for doing a laparoscopy? They said $140. And I said, well, what if you spend 2 or 3 or 4 hours in there and are meticulously trying to remove every bit of endometriosis? $140. They apparently don't get paid any more for doing operative laparoscopy than they do for a regular laparoscopy. Obviously, a physician, whether in Canada or America, cannot make a living being paid $140 for 3 or 4 hours of work. That's not enough money to pay salary, overhead, practice expenses, and you know that really disturbed me, because it told me that with that type of situation, it'd be very unlikely that any Canadian physician is going to be able to afford to do the long, tedious surgeries required for endometriosis treatment, whether through the laparoscope or perhaps even a laparotomy, but certainly not through the laparoscope.
Okay.
You need to pay your physicians more.
Would you care to comment on what you make in
How you get
in some
around
way?
Endometriosis surgery through the laparoscope range from around $1,100 to $1,600 for a case. These cases, again, represent the most severe disease frequently that North America can produce, multiple previous surgeries and multiple previous medical attempts. I believe for 3 or 4 hours of surgery, this is a fair charge for the severity of disease I am seeing.
I mean, if this is true, then in Canada the same thing goes for if they're removing cancer or other I mean, $140 for a surgical operation. I mean, we've got to do something about this.
Could you comment on the cost, all hospital overhead, and those are your costs, but then the hospital charge here, we've assigned a flat rate to patients with endometriosis. This includes their time in the operating room, their recovery room, their overnight stay in the hospital if needed, room and board, all drugs, etc., for $2,200 for that stay.
Okay, endo and information. We want to know, is the most current information on endo readily available to medical practitioners in Canada and the U.S. and their patients?